Welcome to Weekly Neurology Deep Dive, produced by Amer Gavanini. Today we're diving into a really important area for clinical practice, the ongoing difficulty in getting the diagnosis right for vascular cognitive impairment and dementia. And for you, the practicing neurologist, this is key. Vascular dementia is, after all, the second most common type, maybe about 15% to 20% of cases. But even bigger picture, cerebrovascular disease might play a role in cognitive decline for, well, maybe up to about 75% of all dementia cases. So it's hugely relevant. Now, before we get started, just the mandatory bit. This deep dive is strictly for educational purposes. There's no commercial goal here. It's a summary. We strongly recommend you read the full consensus paper itself. It's titled Revised Diagnostic Criteria for Vascular Cognitive Impairment and Dementia, the VasCog-2-WSO Criteria. Our goal today is to unpack these new international criteria. They came out of a pretty rigorous Delphi study with 70 international experts, so they carry some weight. Let's start with a quick practical summary right up front for those short on time. The main takeaway.
These criteria update the older 2014 International Society of Vascular, Behavioral, and Cognitive Disorders guidelines, and they do it with very operationalized, step-by-step guidance. The standard term now, the umbrella term, is vascular cognitive impairment and dementia. It covers the whole range. And the core change, the practical bit for neurologists, is really in box 2 of the paper. It refines the clinical and neuroimaging standards. They're more specific now about thresholds, lesion locations, that kind of thing. And importantly, biomarkers, like for Alzheimer's disease, they're integrated, but mainly to point toward other potential causes or mixed causes, not really to define the vascular problem itself.
That standardization is probably the most critical part. Historically, this has been a real headache. We had the 2014 International Society of Vascular, Behavioral, and Cognitive Disorders criteria, sure, but also guidelines from the National Institute of Neurological Disorders and Stroke, the American Heart and Stroke Association, the 2018 Vascular Impairment of Cognition Classification Consensus Study. And they all varied. Different terms, different ways to assess patients. It made comparing research, let alone clinical trials, incredibly difficult. A fragmented landscape, really.
So previous attempts didn't quite achieve that universal standard. What gives these new criteria a better shot? You mentioned the process.
It was definitely robust. They used a modified Delphi consensus method. 70 international experts were invited, and between 49 and 54 actually participated across 3 survey rounds. And getting agreement wasn't easy. They set a high bar, needing about 75% or more agreement on each point to reach consensus. Plus, the final criteria got the official endorsement from the World Stroke Organization. That adds significant authority and hopefully promotes wider adoption. And a major outcome of that process was nailing down the terminology. That overarching term, vascular cognitive impairment and dementia, got about 84% agreement in the final round. So now we have consistency. Vascular mild cognitive impairment for the milder end, and vascular dementia for the major dementia level severity. That consistent spectrum is a real plus for future work.
Okay, let's pivot to the clinic. A patient comes in. The first diagnostic step, according to box 1 in the criteria, is figuring out the severity of the cognitive loss. You said this part is similar to the 2014 criteria.
Largely, yes, it sets the stage. You first need to establish whether you're dealing with vascular mild cognitive impairment or full vascular dementia. So, for vascular mild cognitive impairment, you need 2 things. 1, there have to be concerns about a decline in cognition, either from the patient informant or you, the clinician. And 2, objective testing shows modest deficits. Modest usually means, say, 1 to 2 standard deviations below the norms for their age and education, or maybe between the 3rd and 16th percentiles. But crucially, and this is the key distinction, these deficits are not bad enough to interfere with their independence in daily activities.
And for vascular dementia?
For vascular dementia, the concerns about decline need to be significant. The objective testing needs to show clear deficits, typically 2 or more standard deviations below norms or falling below the 3rd percentile. And here, there must be evidence that this cognitive impairment interferes with their independence. Usually that means they need help with instrumental activities of daily living, things like managing money, medications, complex tasks.
Interesting that they harmonize the cognitive domains listed in box 2 with the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, moving away from the older 2014 domains. Why that change?
It just makes sense for consistency. Aligning with a widely used framework like the Diagnostic and Statistical Manual of Mental Disorders simplifies integration across different diagnostic systems you might be using. So the domains are now Attention and processing speed, executive function, learning and memory, language, and perceptual motor function, which includes things like praxis and gnosis. And this matters clinically. We often see attention, processing speed, and executive functions being affected quite early, especially in small vessel disease. Also, if memory is impaired early on in vascular cognitive impairment and dementia, it tends to be more of an inefficient encoding or retrieval problem. That's a helpful clue to distinguish it from the classic consolidation and storage deficit you see more often in Alzheimer's disease.
All right, let's drill down into the real operational heart of this for us neurologists. Box 2. Establishing that the cause is predominantly vascular. This seems to be where the major updates in specificity lie. You need both condition A, clinical features, and condition B, neuroimaging.
Exactly. Both are required. You need clear evidence linking the cognitive issues to underlying cerebrovascular disease. So condition A, the clinical features. There are two main ways to satisfy this. The first, pathway A.1, is the temporally related to stroke presentation. Here, the onset of cognitive problems has to be abrupt, clearly linked to a stroke event. And importantly, those deficits have to persist beyond 3 months after that stroke. They kept that 3-month guidance. They also added a practical note. If the stroke history isn't crystal clear, but you find physical signs consistent with stroke, maybe a hemiparesis, a Babinski sign, pseudobulbar signs that can support this pathway too.
Makes sense. But what about the more common scenario, perhaps, of a slower decline without a big, obvious stroke?
That's pathway A.2. Decline from subcortical ischemic pathology. This is your gradual onset, slowly progressive picture. And the deficits typically hit attention and processing speed and/or executive function most prominently. Supportive features might include personality or mood changes, maybe some gait or balance issues. But interestingly, they specifically removed general gait disturbance and urinary frequency as essential features for the diagnosis here. The consensus was they're just too non-specific in older adults.
Okay, let's talk imaging, condition B. This requires specific findings, preferably on magnetic resonance imaging, but computed tomography is acceptable. What really jumps out is the level of quantification needed. How does this address the old problem of variability in interpreting scans?
It addresses it head-on by setting concrete, measurable thresholds. No more vague descriptions like mild or moderate changes. And it anchors everything to the standards for reporting vascular changes on neuroimaging 2 definitions, the STRIVE-2 guidelines. So you need at least one of 4 specific imaging patterns. First, infarcts. You either need multiple infarcts present or even a single infarct can count if it's large or strategically located, think thalamus, angular gyrus, that sort of critical area. Second, lacunes. The criteria specify 2 or more lacunes located outside the brainstem, or again, a single lacune might be enough if it's strategically placed, or if it occurs along with extensive white matter hyperintensities. That strategic placement idea is key, linking the lesion location to potential cognitive impact.
Right, and white matter hyperintensities themselves, that's always been a tricky area. How much is enough to meet the criteria now?
They've really tightened this up using the Fazeka scale, which most neurologists are familiar with. The third imaging option is white matter hyperintensities. They need to be extensive and confluent, specifically corresponding to an overall Fazeka score of 2 or 3. Or they offer regional cutoffs. A periventricular Fazeka score of 3 qualifies, and/or a deep white matter Fazeka score of 2 or 3 also qualifies. This gives you clear objective thresholds for significant small vessel disease burden. And the fourth imaging pattern is intracerebral hemorrhage. Similar logic applies. One hemorrhage might be sufficient if it's large, involves a lobe, or is strategically placed, or simply having 2 or more hemorrhages anywhere would meet the criterion.
So you establish the cognitive impairment level from box 1, then you satisfy both the clinical pattern, condition A, and the specific imaging findings, condition B, from box 2. But we know pure vascular dementia isn't always the case, especially in older patients. How does section C of box 2 handle mixed pathologies?
Section C is really important for that reason. It explicitly addresses features that might suggest something else is going on, either instead of or alongside the vascular disease. This acknowledges the clinical reality of mixed dementia. This is where biomarkers come in. If you have positive biomarkers for, say, Alzheimer's disease, things like cerebrospinal fluid or plasma amyloid beta and phosphorylated tau changes, or a positive amyloid positron emission tomography scan that provides evidence for concomitant Alzheimer's pathology. The same applies to biomarkers for dementia with Lewy bodies, like dopamine transporter imaging. The criteria basically say, yes, you can diagnose vascular cognitive impairment and dementia with concomitant Alzheimer's disease, or other pathologies if the evidence is there. It provides a framework for that mixed diagnosis.
And I noted they specifically removed major depression as an exclusion criterion.
Oh.
Why was that?
Yes, that was a conscious decision based on the consensus. There's just so much overlap in symptoms between depression and vascular cognitive impairment and dementia, particularly later in life. They often coexist and interact. So keeping depression as an absolute exclusion was felt to be clinically unhelpful, even inaccurate sometimes. Its presence doesn't rule out a vascular contribution anymore.
Okay, wrapping up the core criteria, let's look at box 3, the levels of diagnostic certainty. How do we get to probable vascular cognitive impairment and dementia?
A diagnosis of probable vascular cognitive impairment and dementia requires that your clinical criteria are backed up by that specific neuroimaging evidence we just discussed in box 2, condition B. Alternatively, you can reach probable if you have the clinical picture, plus genetic evidence of certain hereditary cerebrovascular diseases. They specifically list conditions like cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy and others. Integrating genetics here is a nice touch. If the clinical criteria are met, but you don't have that definitive neuroimaging or genetic proof, maybe imaging wasn't done or wasn't conclusive, then the diagnosis is considered possible.
And there's a completely new category introduced, aimed at people without symptoms yet. The preclinical or at-risk category. That sounds like a shift towards prevention.
It really is. This preclinical at-risk vascular cognitive impairment and dementia category is quite forward-looking. It applies to individuals who are cognitively normal, no complaints, perform normally on testing, don't meet criteria for even mild cognitive impairment. But on neuroimaging done for other reasons perhaps, they show significant evidence of cerebrovascular disease. Enough evidence, in fact, to meet condition B of box 2, those imaging thresholds we talked about. The purpose here isn't dementia diagnosis, obviously. It's about identifying individuals who, despite being cognitively healthy now, have a significant vascular brain burden that puts them at high risk for future decline. This allows us to target them for really intensive risk factor management, lifestyle interventions, and potentially enroll them in preventative clinical trials. It's moving the field towards primary prevention based on imaging biomarkers.
Okay, let's try to synthesize this for the practicing neurologist listening. If you had to get the main take-home message from these revised diagnostic criteria for vascular cognitive impairment and dementia, what would it be? It seems the biggest shift is towards highly operationalized specific steps. You need both a clear clinical pattern, either the stroke-related one, or that gradual subcortical type and concrete quantified neuroimaging evidence, like that Physika score 3 or the strategically placed lesions. And crucially, there's now a clear pathway to incorporate biomarkers like those for Alzheimer's disease, not to exclude the vascular component, but to formally recognize and diagnose the common scenario of mixed pathology.
Absolutely. And connecting this to the bigger picture, these revised diagnostic criteria for vascular cognitive impairment and dementia provide a much-needed, robust international standard for clinical diagnosis right now. But they also highlight a gap. Neuroimaging, particularly magnetic resonance imaging, remains absolutely central to making a probable diagnosis. Why? Because we still lack widely available specific molecular biomarkers for the vascular pathology itself, unlike what we have for Alzheimer's disease, for instance.
That really tees up a final thought for you, our listeners, to consider. Validating these criteria in large, diverse, longitudinal studies is clearly the next step. But beyond that, how quickly can the field develop and validate reliable molecular biomarkers, specifically for cerebrovascular contributions to cognitive decline? Will we eventually secure a probable vascular cognitive impairment and dementia diagnosis based on molecular evidence, moving beyond our current reliance on imaging patterns? Something to think about. Thank you for joining us for this weekly Neurology Deep Dive.